Hello everyone. So today we will be discussing troubleshoot problems of gestational diabetes mellitus and preterm labor pains. Yes, we discussed twins also today in the quiz, but here I'm not discussing so that this video is uploaded on time. Okay, if I would have had the twins class, then it would be 9 or 10 p.m. Okay, so to be on the time, I'm postponing the twins discussion to tomorrow. Okay, so first of all, both these topics are important, and you can say that one question is expected from the last 2 3 exams. Continuously questions are coming on preterm labor pains in all the exams, NEET, PGI, and set and FMG. All the exams, they have started putting the question of preterm labor pains. So it is highly expected from this class we will get one question. Okay, and today we will learn the management concerned with gestational diabetes mellitus and the preterm labor pains. Okay, so let's start it. So first of all, first and the foremost concept which we do wrong is that, see, there are two different things. One is gestational diabetes mellitus and second is the overt diabetes mellitus, or you can say the another name of overt diabetes mellitus is pre-gestational diabetes mellitus. Okay, so what is difference between gestational diabetes mellitus and overt diabetes mellitus? The one diabetes which is pre-existing before the pregnancy is known as overt diabetes mellitus or gestational diabetes mellitus. And what is gestational diabetes mellitus? The one which occurs, the diabetes which occurred for the first time during the pregnancy is known as gestational diabetes mellitus. Okay, now the question is, in which pregnancy will the congenital anomalies occur in fetus? Okay, so here I would like to tell you, congenital anomalies, it occurs in fetus if the sugar levels are deranged during the organogenesis. Okay, that is in the first 3 months. Got it? So congenital anomalies, it occurs in the fetus only and only if the sugar levels, they are not in balanced, or not in they are deranged in during the organogenesis. And you all know that organogenesis occurs in the early pregnancy. Now the gestational diabetes mellitus, the one which occurred during the pregnancy, it occurs at 24-week to 28-week. Okay, because at this time, at this period of gestation, the insulinase action of human placental lactogen is maximum. Okay, so in gestational diabetes mellitus, there is no fetal congenital anomalies. Okay, all the congenital anomalies occurs in the overt diabetes mellitus. Got it? Once again, I will tell you that the congenital anomalies in the fetus, they will only occur if the sugar levels in the mother are deranged during the organogenesis of the fetus. And you all know organogenesis occur during the first 3 months. Okay, and the gestational diabetes mellitus, the one which is occurring only in the pregnancy, it occurs at 24 to 28 week, because at that time the insulinase action of the human placental lactogen, the hormone which is secreted in the placenta, is maximum. So diabetes occurs to mother. Okay, so if the patient is having gestational diabetes mellitus, it means its sugar level will be deranged after 24 to 28 weeks. So in that case, there will be no congenital anomalies in the fetus of the gestational diabetic mellitus mother. Okay, all the congenital anomalies, we will discuss it later, will occur only in the mother of overt diabetes mellitus, in the mother with overt diabetes mellitus. Okay, so that was about the congenital anomalies will occur in gestational diabetes mellitus or pre-gestational diabetes mellitus. So it will occur only and only in the pre-gestational diabetes mellitus. The most common system which is affect due to the diabetes in the mother is cardiovascular system. Okay, and VSD is the most common cardiac defect. Okay, lot of students, you have messaged me ki ma'am VSD is not the most common, TGA is the most common. Dear, I have checked 2 times from the standard book, I have found the same. Okay, so once again, yes, so VSD is the most common cardiac defect which is found in the mothers of overt diabetes mellitus fetus. Okay, and if we talk of more specific, then the most specific is TGA, transposition of great arteries. Okay, now the second most common system which is affected is neural system or the central nervous system. And what are the defects? So it is a neural defects which occur. Okay, spina bifida, anencephaly. So these are the second most common defects. The most specific defect of the most specific congenital anomaly in the fetus of the overt diabetes mellitus mother is sacral agenesis. So this was a picture which was once given in the NEET PG. As you can see in the x-ray of this newborn, there is no sacrum bone. So this is a image of sacral agenesis. Okay, proceeding to the next slide. Now how is the diabetes mellitus managed? Okay, so first of all, we have to restrict the calories. So usually we give 40 kilocalories per kg per day to the pregnant mother. So here we will restrict it to 25 to 30 kilocalorie per kg per day. And we'll also tell the mother to do exercise, like do the walk. Okay. So insulin is the drug of choice. If on the diet and exercise this diabetes is not controlled, then we have to give insulin. So 2 more drugs are approved for the gestational diabetes mellitus or overt diabetes mellitus. They are glyburide or glibenclamide. They both are one and the same, and another drug is metformin. So these are both drugs are approved, but the insulin remains the drug of the choice. Termination of the pregnancy is usually delayed. As maximum it can be delayed, but as we will discuss it after some time, that in the fetus of the diabetic mother, there is in the fetus of the diabetic mother there are chances of IUD or IUD due to the sudden, when the mother will have sudden hypoglycemia, then the fetus will also have sudden hypoglycemia, and then the IUD can occur. Okay, so we have to see both the factor, that we have to take the pregnancy as late as we can take, because the lung maturity of the fetus is delayed in a diabetic mother. So we have to take the pregnancy as much late as we can take, but simultaneously we have to keep this thing in the mind, that if we are going to delay the pregnancy, then there are chances that if fetus can undergo IUD. Okay, so maintaining both these things, we have come up with this protocols. If it is a diet controlled gestational diabetes mellitus, then the fetus then the pregnancy is terminated at 40 to 41 weeks. Okay, it means we will take the pregnancy to maximum. And if it is a drug controlled gestational diabetes mellitus, then it means the sugars are controlled, and then we will terminate this pregnancy to 39 week to 39 weeks 6 days. Okay, and in the case of drug controlled over diabetes mellitus, we will terminate the pregnancy at 37 weeks, and if in the case of the uncontrolled over diabetes mellitus, we will terminate the pregnancy at 34 weeks. Okay, I hope everything is clear to you now. Now, how we will diagnose the gestational diabetes mellitus or over diabetes mellitus? Here I would like to tell you, first of all, there are three criterias. Number one is IADPSG, which is an international association. What does the IADPSG say? Same is said by ADA, American Diabetes Association. Okay, don't get confused. If I is written, then it is Indian. No, I is for international there. So both are one and the same, and usually this is only what is followed. The second criteria is given by Indian Society, DIPSI. Okay, and the third criteria are given by ACOG. Got it? Now let us study the three criterias, because all of these three have been asked in your exam, so you have to learn all of these three. See, it's very simple. Just listen here. IADPSG say whatever is the screening is same as the diagnostic, that is the glucose challenge test. Here we do the glucose challenge test with the help of 75 gram glucose. We do it only once at 24 to 28 weeks. We call the patient fasting. Okay, and we give 75 gram glucose. Patient drinks it by mixing it in water, and the values for the to diagnose gestational diabetes mellitus, the cutoff values: fasting is 92, 1 hour is 180, and 2 hour is 153. Here you have to learn each values the same way. How we remember is 92 is something, its double is 180, and then going back is 150. Okay, for the over diabetes mellitus, the values are, yes, 126 fasting. If it is more than 126, then it is over diabetes mellitus, and 2 hour value is 200. Okay, now what does the DIPSI says? DIPSI says that, the Indian Society says that, as you all know, females, or our Indian society is Indian females are much less aware. If we will call them the next day saying that tomorrow you come fasting, they might not come. Okay, so they say that they have Indian females, or Indians are more prone to diabetes because they belong to Asian community. So 2 times they have to be tested. First time when they come for the first antenatal visit, and second again in the 24 to 28 weeks. And here we are doing non-fasting, and here we give the mother to drink 75 gram glucose challenge test, and we take only one value after 2 hours. Okay, so it says if it is more than 140, then it is gestational diabetes mellitus, and if it is more than 200, this value, it is over diabetes mellitus. This was a DIPSI criteria. So in the DIPSI criteria, you have to learn only 2 values, whereas in the IADP-CSG you have to learn many values. Okay, now what does ACOG says? ACOG says that there are 2 tests. One is 50 gram glucose challenge test, that is to be given to the patient. 50 gram sugar patient has to take, and then we will give that is also non-fasting, and then we will see what is the value blood sugar levels after 1 hour. If they are more than 140, then the patient will go for the diagnostic test, which is a 3 hours 100 gram glucose tolerance test. Okay, so as per ACOG, there are 2 tests. One is screening test, which is 50 gram glucose challenge test, in which in the non-fasting state, right, we give the patient to drink 50 gram glucose in water, and then we take 1 hour. After 1 hour we take the value. If it is more than 140, then the patient undergoes the glucose tolerance test, which is 100 gram 3 hours. So because it is 100 gram 3 hour test, so here there will be one value fasting, one value 1 hour, one value 2 hour, then one value 3 hours. So totally there will be 4 value fasting, and every hour value. So totally there will be 4 values. So you just remember that the first three values of the 3-hour 100-gram glucose tolerance test are somewhat similar to the 75-gram glucose tolerance test, and fourth value you don't remember. Okay, so that is what I always say is ki just remember as minimum as you can, and that you can recall in the exam. Okay, so this was all about how to diagnose the gestational diabetes mellitus and overt diabetes mellitus. So what are the complications which occurs in the fetus in utero? When the fetus is in uterus, what all complication occur? First of all, already explained to you that when mother will have the hypoglycemia, then the fetus will also have the hypoglycemia. So fetus can abort or they can be IUD. Okay, then macrosomia is there due to the hyperglycemia in the fetus, as there is hyperglycemia in the mother. In the same way, there is hyperglycemia in the fetus, so macrosomia occurs. Okay, what are the complications in the infants or newborn? Now this in utero fetus has came out. What are the complications? As you all know, this fetus, it suffers from hypoglycemia. So now this time there will be no hyperglycemia, there will be hypoglycemia, because this fetus has came out, and all the ions, whether it is potassium, calcium, sodium, phosphate, all the ions will also be in the hypo stage. So hypokalemia, hypophosphatemia, hyponatremia, hypocalcemia, and sometimes there is hyperviscosity syndrome, due to which there is polycythemia or hyperbilirubinemia. Okay, only so two hypers, polycythemias and hyperbilirubinemia, in the infant of a diabetic mother. Otherwise all hypos, including hypoglycemia. In the maternal, what are the maternal complications? So you should know that polyhydramnios occurs. Then PPH can occur because this time there is macrosomia and uterus is over distended. Preterm labor pains and PROM can occur, as we will study just after a few minutes. Preterm labor pains also occur in over distended uterus. Shoulder dystocia, you all know it, and because of macrosomia and all these problems, there is high incidence of cesarean section in the mother. Okay, now let us go to the preterm labor pain. That was all about the diabetes in pregnancy. Let us go for preterm labor pains. So what is the definition? You all are doing so much wrong in the definition of preterm labor pain. Please listen carefully. In the today's quiz, you only did 30% right in this definition. Better just listen carefully. You will be able to do next time. You all will be able to do it right. So first of all, what is definition? Definition is regular uterine contractions. So the contraction, to diagnose a patient as preterm labor pains, it should be a regular uterine contractions, and these contractions should be 4 in 20 minutes. See, whenever we are palpating the uterus, we are palpating it for the contractions, we palpate it for 10 minutes, but here it is 4 in 20 minutes or 8 in 60 minutes. Okay, so this duration is somewhat different. Okay, 4 in 20 minutes and 8 in 60 minutes. So please keep a watch on it. And if the cervix is dilated 1 centimeter or more, then again it is a preterm labor pain. And if the cervix is phased more than 80 centimeter. As I already told you, in Bishop's score also, where we were assessing the cervical status of the patient in labor. Okay, there also the two main components were cervical effacement and cervical dilatation. Do you remember? Yeah, so there were two main components, cervical effacement and cervical dilatation. No doubt cervical dilatation was the most important component, and after the two components were cervical consistency and cervical position. Okay, so but here only they have taken the two component, effacement and dilatation, and the third component is regular uterine contraction, 4 in 20 minutes or 8 in 60 minutes. Okay, but to diagnose a patient at preterm labor pains, in all this there should be fetal membranes should be intact, because if their fetal membranes are not intact, then it is a case of PROM. right? And the period of gestation should be less than 37 weeks. Got it? Next is, which of the following is not a criteria of, this was a question which you did wrong. Okay, this was the INSET May 2022 question. Cervix more than 1 centimeter dilated, it is right. Okay, contractions 8 in 60 minutes or 4 in 20 minutes, it is also right. More than 80% cervix efface, it is also right. Cervix posterior or central. Now see, we have studied this in Bishop score. If the cervix is posterior or central, it means that cervix is not in favor of labor. So from that knowledge we will mark the answer as D, because the cervix is posterior or central, it means that the cervix is not in favor of the labor. Okay, now let's study threatened preterm labor pains. The length of the cervix, what is threatened, it means that there is no preterm labor pains, but they can occur. There is a fear that the labor pains will occur. It will there when there are no uterine contractions, but the cervix length is less than 2.5 centimeter. Okay, when there are no uterine contractions and the cervix length is less than 2.5 centimeter. What are the risk factors for the preterm labor pains? There is history of the preterm labor pain is the most consistent risk factor. So mainly 3 factors you have to remember. So here again I would like to tell you, always shorten your list. जितनी आप अपनी लिस्ट छोटी करोगे ना, उतना रिवाइज करना आसान है, उतना एग्जाम में सक्सेस लेना आसान है. ठीक है. सो इन द डिस्टेंडेड यूट्रस देयर इज अ रिस्क ऑफ प्रीटर्म लेबर पेन्स बिकॉज देयर इज पॉलीहाइड्रोमिनोस. इन द डिस्टेंडेड यूट्रस देयर इज अ रिस्क ऑफ प्रीटर्म लेबर पेन्स because uterus gets distended and there is release of prostaglandins which induce the labor pains. Okay, so in the polyhydramnios the uterus is distended, in the twins the uterus is distended, in the diabetes the uterus is distended. So whenever the uterus will be distended, then there will be preterm labor pains. And then in the infections, what all are the infection? Asymptomatic bacteriuria, then UTI, vaginosis, these all are the infections which occur. Okay, and this they or prom, you can say, this all they prone the patient to preterm labor pains. Okay, abruption and preeclampsia because they interfere with placental integrity, so they also cause preterm labor pains. So there are only 3 risk factors which you have to learn: distended uterus, infection in the uterus, and abruption and preeclampsia. And you should know that history of preterm labor pain is the most consistent risk factor which is found in the patients with preterm labor pain. Next is how you will diagnose. Today there was a lot of discussion on this question, so let us clear it. Okay, diagnosis of preterm labor pain is by fetal fibronectin. So what is fetal fibronectin? It is a glycoprotein that binds the fetal membrane. What are fetal membranes? Amnion and chorion to the decidua. Okay, so it is a glycoprotein that binds the fetal membrane, amnion and chorion to the decidua. That is why these membranes, they are bind to the decidua or the endometrium. Okay, now when labor pains will occur, then obviously this fetal fibronectin will get released. There will be no binding. Okay, so normally this fetal fibronectin is present before 24 weeks and after 34 weeks. Okay, there's a bit controversy 34 or 37, but both are diagnostic of preterm labor pains. Okay, so if you want to learn it easily, you can remember 24 to 34 it is absent, and present before 24 and after 34. So before 24 weeks it is not diagnostic of preterm labor pain, and after 34 weeks it is again not diagnostic. It's present between the 24 and 34 weeks is diagnostic of preterm labor pains. Okay, now the next is what is the treatment if it is a threatened preterm labor pains. As I already told you, in threatened preterm labor pains the cervical length is shortened but there were no uterine contractions. So here we will do cervical encerclase and corticosteroids. We will give the patient corticosteroids to enhance the fetal lung maturity. And if it is a case of preterm labor pains, then of course we will give the patient corticosteroids for the fetal lung maturity and tocolysis. Okay, tocolysis, that is to silent the uterine contractions. So let's study about them. These days lot of questions are being asked on this. Corticosteroids, there are two type of corticosteroids which we give. One is dexamethasone and another is betamethasone. The doses of dexamethasone is 6 mg. We have to give every 12 hourly 4 doses. Okay, 6 mg, then 12 hours gap, then 6 mg, then 12 hours gap, then 6 mg, then 12 hours gap, then 6 mg. So 4 doses of 6 mg with 12 hours gap in each dose. And for the betamethasone, to give betamethasone, we give 12 mg, 2 doses at a gap of 24 hours. Okay, so if we calculate the total of both dexa and beta is 24. Okay, so it is in the betamethasone it is 12 into 2 at a gap of 24 hours, and in the dexamethasone it is 6 into 4 at a gap of 12 hours. Okay, now these steroids, they gives the lung maturity to the fetus. Okay, and but they are contraindicated in chorioamnionitis. Why they are contraindicated in chorioamnionitis? Because you see already the fetal membranes have been infected here. It means if we will give the corticosteroids to the mother or fetus, then the infection to the fetus will increase. So one sided we are giving the steroids to increase the lung maturity, and on the other side we are proning the fetus to infection. So we will not do this thing, because it is highly contraindicated. So if a mother has chorioamnionitis, then we will not give the mother steroids. Okay, next is tocolysis. For the tocolysis, the drug of choice is nifedipine, okay, which is a calcium channel blocker, and its side effects are headache and hypotension. You all know, okay. And the second drug which we use, and a lot of questions are asked on this section, okay, is the beta agonist section. The name of the drugs are ritodrine, terbutaline, and isoxsuprine. You have to learn all these names. Questions are asked, and as they are beta agonists, they will cause peripheral vasodilation and tachycardia, hypotension. Okay, all these questions are asked because these drugs, ritodrine, terbutaline, and isoxsuprine, they are beta agonists. They cause peripheral vasodilation. As a result, hypotension and tachycardia occur, and soon to the patients who are susceptible, they go into high output cardiac failure. Now there is hypokalemia and all hypos except hyperglycemia. Okay, so due to these two things, it is contraindicated in maternal cardiac diseases and diabetes in pregnancy. So you have to learn this. Last time in the June 22 question came here on hypokalemia or hyperglycemia or hyperkalemia, hypoglycemia. This way there were 4 options. So remember that there is hypotension and all hypos except hyperglycemia. Okay. Okay. So the other drugs which we can use is mexsulfate. We have read in detail about mexsulfate that it can use for the neuroprotective for the mother and the fetus in the preeclampsia and eclampsia. No need to discuss it here. Indomethacin, which is a prostaglandin synthetase inhibitor, can also be given, but its side effect is it causes premature closure of ductus arteriosus. So it is not used after 32 weeks. Okay, so here again I'm going to tell you this on this fact that it causes premature closure of ductus arteriosus, have been asked in NEET PG and I think once in FMG also. Okay, so please focus on this point. And this indomethacin, it is also used in polyhydramnios patients before 32 weeks because it decreases the urine output of the fetus and treat polyhydramnios. Okay, so because the amniotic fluid is nothing but amniotic fluid is nothing but fetal urine. So if the fetal urine will get reduced, then polyhydramnios will get treated. Okay, so here you have to keep in mind that you have to keep in mind that this indomethacin has two uses. One is tocolytic action, and another is in the patients of polyhydramnios. In both condition, we will not give it after 32 weeks because of its common side effect that it causes premature closure of the ductus arteriosus. Okay, nitroglycerin patch, because it causes nitroglycerin patch is also used, and atosiban is oxytocin antagonist. Okay, so if the question comes, which of the following drug is used in the heart diseases patient, so it is atosiban. Okay, last but not least is the PROM, premature rupture of membrane. So for to diagnose premature rupture of membrane, okay, there is a test called as nitrazine test, which is basically a litmus paper like paper, nitrazine paper. And you all know that amniotic fluid is alkaline in nature and cervical secretions, they are acidic in nature. So we take the cervical fluid, because when a patient has PROM, it is very difficult to diagnose whether that PROM is due to whether the fluid which is coming out of the cervix is amniotic fluid or the cervical secretions. Okay, because both are transparent in nature. So we take that fluid and put the nitrazine paper on that fluid. Nitrazine paper is a yellow color paper. Okay, and as the amniotic fluid is alkaline in nature, so the nitrazine paper gets turned to blue, and because the cervical secretions are acidic, so nitrazine paper turns red. So that way we diagnose that whether the fluid in the cervix was the amniotic fluid or the cervical secretions. Okay, so nitrazine test R is for PROM. So there are a lot of tests, but this test is most frequently done and most frequently asked, and it's high time, so we are going to learn the most frequently done test only. And for the preterm labor pain, the test was fibronectin. Okay, so that was all about the gestational diabetes mellitus and preterm labor pains. Do like, share and subscribe my channel. It means a lot to me. It will help me in my teaching journey, and yes, it will encourage me too. Thank you. See you soon in the next video tomorrow.